So yeah, I've been given the impossible task of describing how we can use imaging to try to track the recovery process and understand it better. So I I am an imaging guy, so this is definitely in my wheelhouse, but nonetheless a very challenging task, I think. But bear with me, and we'll see what we can do here. I think one of the certainly this talk is going to be fairly speculative and maybe a little provocative, but every discovery started in someone's imagination, right? So so we'll go through this, and it's going to be a very MRI heavy talk, because that's what I do. And so we'll look into some of the MRI sequences that many of you are probably familiar, but maybe haven't seen in this context. So at minimum, hopefully get a nice dose of imaging as we go through this. Sorry. Service right now. Okay. So imaging recovery after stroke. What can MRI tell us about recovery sort of right now? It's an open question. Some people may have different opinions about it. From what I can tell at this point, other than the location of the lesion and the size of the lesion, there's not really much that MRI tells us about recovery. Certainly, even that can be deceptive, as I'll get into, with some of the lesions perhaps not representing what we think they represent. So what would we expect recovery to look like on MRI? Certainly, sorry, I'm getting text here. Okay, sorry about that. I'm on service. So what does recovery look like on MRI? Is it below the resolution of MRI? Is this an impossible task? Or is it that we're just using the wrong contrast, the wrong sequences? I mean, MRI basically has infinite possible contrasts and sequences that you can put together. And so, maybe we just haven't hit the right one yet, and we need to think more broadly. So I'll try to touch on all that as we go along. So what about if we could wave a magic wand and decide, what we want MRI to tell us about recovery after stroke? What would we ask of this biomarker? I think probably the first thing we want to know is, can we predict recovery, right? We're very bad at that for the most part. So if we had a way to predict who was going to recover and who wasn't and how much, that would be very helpful to patients. That would be very helpful for management. It would be very helpful for enrollment in clinical trials as we try to advance the field. So certainly predicting recovery would be helpful. And then even better would be if we could actually track the recovery, if we could quantify it in some way, and then potentially even observe modulation should we be able to modulate recovery. So that's another piece that we might ask for. And then ultimately, I think with all these imaging biomarker type research, we really hope that this imaging is going to elucidate the mechanism. So we hope that we will be able to learn from what we see on the imaging and understanding what that imaging represents at the cellular level, and then take that into our understanding of what's happening pathophysiologically. So brief overview of what I'm going to talk about. This talk's going to be kind of broken down into two main sections. So the first part will be about MRI of stroke and evolution, and I'll be particularly focusing on diffusion imaging and what diffusion imaging tells us about MRI and evolution. The second part will be focused on more of the chronic stage of recovery, sort of chronic cerebrovascular disease. I'm going to talk about a little bit about another type of imaging methodology, which you'd probably be less familiar with, which is blood-brain barrier imaging, and sort of what that can tell us about how people do after their stroke and how we might be able to influence their recovery. And then I'll wrap up with sort of some thoughts for moving forward. What's next? What else we might be thinking about? And this, of course, is Mother Brain from Metroid. One of the best games ever. So starting with MRI of stroke and evolution. So when we think of recovery after stroke, we tell patients that most of the recovery is going to occur within the first 3 months or so. You might still be recovering out to a year. But we certainly have this, are of the opinion that recovery happens fairly soon after stroke. At least that's when it happens the strongest, right? So there's this clinical observation, which others may have had or may not, but certainly I've seen this where a patient begins to recover in the hospital. When you see that in the hospital, then when they come see you in clinic, they tend to look really good. So that early recovery seems to be somewhat predictive of the later recovery. So that begs the question, when does spontaneous biologic recovery begin? If we're saying that you're getting the strongest recovery in the very early time frame, how early do we take that? Does recovery begin at the moment we reperfuse the tissue? And I'm thinking it might, and that might explain why some people, when you reperfuse them, despite having a pretty big stroke, they actually clinically go on to do very well, even while in-house. So if recovery is strongest at the earliest time point, the best time to image recovery might be at that time. If we were to try to capture this phenomenon, we want to capture it when it's strongest. So right after reperfusion might be our best bet. So when we think of MRI and stroke, I think most people are comfortable looking at strokes on MRIs and pointing out the lesion. But that's largely based on MRI scans that are done about 12 to 24 hours after the stroke has occurred. And that's really just a logistical aspect of stroke care that, early imaging tends to be CT based, and MRIs usually happen sort of subacute or, in the hours later when the patient's admitted to the hospital. So most people haven't really seen what an MRI looks like in the moments after you've reperfused a stroke. And most people actually aren't that familiar with getting MRIs before you reperfuse the stroke either, at least not in the US, more common in Europe. So I'm gonna talk a little bit about some data though that was collected by the NIH group, which I was part of for several years, because they've been collecting MRI scans for over 2 decades as part of this natural history of stroke study. And I'll take you through some of the data from this and see if there's anything we can glean as we look at these MRI scans in these very early windows. So just a recap of how the NIH stroke team works, because it's helpful to understand where these images come from and what they represent. So when a patient presents to one of the NIH stroke centers, the stroke team is activated and they get basically a clinical MRI first. So this clinical MRI is done very rapidly. I'm actually going to go through one of these hyperacute MRIs with you so you can see what they look like. And that's sort of part of the initial assessment. They have a very fast mechanism for doing this. And at Hopkins, we do it as well, not 24/7, but during the day, we also try to go to MRI first so we can get some of that additional information to make these decisions. So once they've had their clinical MRI, you make a decision about TPA or endovascular therapy or enrolling them in a trial. And then they get consented into this study pretty much right after you give them the TPA or the thrombectomy. And so then they go right back in the scanner. So we call it the 2-hour. It's really the soonest MRI we can get after they've been treated, but it tends to be about 2 hours after the initial MRI. And then they go on to get another MRI at 24 hours, another one at 5 days, another one at 30 days. And so that's this model that's been there for a very long time. So there's this huge data set with all these different time points. So how do you do these hyperacute MRIs? So I'll just take a second to talk about that because people might not be that familiar with using MRI as a primary screening tool for stroke. But generally you can get an MRI as long as you've got everything sort of worked out in about 15 minutes. So the 15-minute MRI scan, one key part of this is weighing the patient before you put them in the scanner so you can mix TPA while they're in there. But the first thing we get is the diffusion weighted image. Obviously, that's going to tell us, is this in fact a stroke or a mimic, which is a very helpful piece of data. And then the second sequence we get is the gradient echo, which is sort of a hemosiderin weighted image, not too dissimilar from the more commonly acquired these days susceptibility weighted image, but the gradient echo in this situation is a faster, less sensitive to motion, sufficient to rule out hemorrhage. So by the time we've got these two sequences, which is about 5 minutes into this, we already know that this person is eligible or ineligible for TPA. So we start mixing TPA at that time point. The next sequence that's acquired is the flare scan. The flare obviously shows us the stroke or lack thereof, depending on how far along the stroke is. So certainly the flare scan is very helpful if we perhaps didn't know when the stroke started. If it was a wake-up stroke, we could help use the flare and the T2 signal change to make a decision about whether someone's eligible for treatment. After that, they get a quick time-of-flight MRA. This just gives us a look at the vessels and is sufficient for identifying a large vessel occlusion. So after you have that, you can start activating your endovascular team. So all of this has to sort of happen, as the MRI is being done, so that we don't lose any time. And then we end the scan with a perfusion-weighted image, which is obviously important if we're going to be doing sort of extended time window thrombectomy, that kind of thing. It's also helpful for diagnosis as well. And then then we can give the TPA. You can either give it in the MRI suite, that's what we used to do at the NIH, or move it back to the trauma bay, which is what we do at Hopkins, and just give the TPA. So in doing this, you wind up with a lot of additional information, of course. This is an example of someone comes in very early. You see the diffusion weighted image here in the ADC. So it's the stroke is bright on DWI, dark on ADC. And these very early images, sometimes it can be subtle, the DWI change, but that the ADC correlate is key to make sure that you don't miss anything. And then the next sequence we get is the gradient echo scan. As I mentioned, this is hemosiderin weighted. It would show us if there was hemorrhage. The other thing that shows up pretty prominently on this scan are the dilated, or not necessarily dilated, but the venous structures become more prominent. And if you go a little higher up, you can see this a little bit better. And basically, this is probably just deoxygenated hemoglobin causing the susceptibility artifact because the oxygen extraction fraction has been increased, and you've pulled all that oxygen out that you can. So the dipole of the hemoglobin molecule is enhanced and creates this artifact. So it's just important to recognize, because that's not blood; those are all venous structures. The other thing you can often see on the gradient echo is the clot itself. It will cause a sort of blooming artifact here shown in the right middle cerebral artery. And then the next sequence we get are the flare scan. So here in this patient, because we know they're very early, we don't expect there to be any flare changes within the stroke itself. Another useful finding on the flare scan are these hyperintense vessels, which are very sensitive and specific for a perfusion abnormality. And then, of course, we get the time-of-flight MRA to assess the vasculature, and we can sort of project that out and show that we have an occlusion there. And so you can kind of see, put them all together, sort of where the time-of-flight vessel ends, the susceptibility gradient echo clot is picked up. And then the last piece of this is the perfusion imaging, which here I've shown a time to peak map, which is very similar to a Tmax map. And so we can use this to look at the area of at-risk tissue, comparing the size of the perfusion lesion with the size of the diffusion lesion. And so the diffusion-perfusion mismatch obviously has become a very powerful tool in us making our clinical decisions. Now, this patient received TPA. This was actually from before the before times, from before thrombectomy became universal, but had a very good response to TPA. We don't really give people a chance to respond to TPA anymore, but this person did, and so this is an hour and a half later, you can see that, interestingly, everything has reversed. So the clearly on the perfusion scan, you have restoration of blood flow, but also the ADC values have gone to normal, essentially, and the brightness on the DWI has also sort of disappeared. So what is the significance of this? Did we save this brain or not? Well, here's the MRI scan from 24 hours. So here you see Now, some of this diffusion signal has come back. Some of the ADC signal has also gone low again. We start to have some of these flare changes as well. This is just gadolinium in the CSF from the previous MRI scan, but that went through the blood-brain barrier. But so nonetheless, you might make the argument, well, the lesion went away, but then it came back. So, either they improved and then they worsened, or maybe they never got better at all. So that leads to the question of, transient reversal of DWI lesions with early reperfusion. What's the significance of this? And the literature is actually mixed on this. Some papers claim that since it came back, it's not beneficial. It's sort of a transient phenomenon that's not relevant. But if that were the case, if the lesion sort of came back, you would expect the patient to deteriorate in some way, or at least never to have gotten better. And so really the question is, what does the patient look like? Do they look like their 2-hour MRI scan, or do they look like their 24-hour MRI scan? And the reality is they look like their 2-hour MRI scan. And I can just say this from experience, because this is such a common phenomenon if you image at this very early time point to see this. And essentially the patients, when they have this phenomenon, do extremely well. They don't actually tank or in any way deteriorate. And if anything, they're just getting better during those first 24 hours. And we actually demonstrated this in this paper here, where we were asking this question: what was going to be the best predictor of recovery in the first 24 hours after receiving TPA? And so what we found, we looked at 3 different things. We looked at change in the perfusion volume, right? We would expect that to predict someone doing well. We change in the diffusion lesion, so that ADC reversal piece of it, we looked at that. And then, of course, the sort of industry standard, which is final infarct volume, right? We use that in probably has too big a role in when we look at outcome measures, but it is what is used a lot. And so what we found actually was that final infarct volume performed the worst, which is not that surprising, because a lot of these lesions, if they reverse and come back, probably are not clinically significant, or at least are not a marker for brain injury in the way that we think they are. And what performed the best, even better than perfusion changes, was this reversal of the ADCs. So if you have this reversal of ADCs in the minutes to hours after you reperfuse, this was the best predictor of having an improvement in your NIH stroke scale at 24 hours. So this kind of brings up this common clinical scenario. I don't know how other people have had this. I feel like I see this all the time, where a patient presents with a disabling deficit suggestive of stroke. So we do, you do the old school way, and you get a head CT, looks negative, you give them TPA. And then the next day, all the deficits are gone. And you say, all right, we saved it. We've clinically averted the stroke with TPA. But of course, we get that MRI 24 hours out. And when we do that, what we see is there's actually a pretty big stroke on there. And it's always a little bit of, a question of why is that? If the patient looks so much better, why does their MRI look better? And so this comes to one of my rules of stroke imaging, which is that localization is a one-way street. So I can show you a patient and you can examine them and you can describe what the MRI is going to look like. We're pretty good at that, right? We pride ourselves on that. And I think we are pretty good. But if I show you an MRI scan with a stroke on it and ask you to describe the patient, most of the time you're going to be wrong. I mean, you might be in the ballpark, but many times I can show you stroke MRIs where the patient is completely normal. So this is the conundrum of why do 2 stroke patients with the same MRI appearance have very clinically very different deficits? I think, what this gets to is in the moments after reperfusion, some of these DWI ADC lesions reverse and some do not. So in that paper, we went through, there were plenty of people who did not have the reversal as well. It's not a universal thing. And then the other piece of this is that there is this sort of brief return of cellular function. So basically when the ADCs normalize like that, that means that the cells have returned, the ions are pumping, they've reestablished their ion gradients, And so it looks for a minute there like the cells are doing well, but then over the next 24 hours, some of that function is lost. So this improvement over the first 24 hours appears to be a marker for overall good recovery. So the question then becomes, is DDI reversal a biomarker for recovery? And I don't know the answer to that question. It's the closest I've ever seen to capturing something that's very predictive of clinical improvement after stroke. Exactly what that means at a molecular level is, I think, a complicated question. So I think it's an open question and really one to pursue further. All right, so I'm going to now move on to the second part of this, which is thinking more about after the stroke and what we can learn about in the days after a stroke that might help us understand recovery and how we might be able to image that. And specifically, I'm going to talk about this method for looking at the blood-brain barrier, because as I'll show you, it may be playing an important role. So what is recovery after stroke? I'm getting philosophical here. One person experiences spontaneous biologic recovery while another does not. Why is that? We've all seen it. Is it genetic? One person has the capability and one person does not. That's entirely possible. Or is it due to some sort of secondary process where everybody has the capability to recover, but in some people it's being suppressed? And if that's the case, what might it be that would be suppressing recovery? What is it that, rather than promoting recovery, maybe we just need to relieve it from the things that are inhibiting it? And one of the things that's sort of been emerging and that we're starting to get a better understanding of is that there is this post-stroke inflammatory cascade, which may be deleterious and could have an effect on outcomes after stroke. And one of the main ways we look at inflammation in the brain, particularly in other diseases like MS or infections, is disruption of the blood-brain barrier. It's thought that this is a biomarker of inflammation. So what's the role of the blood-brain barrier in stroke? Well, I'm going to talk a little bit about a method now, that an imaging method for looking at the blood-brain barrier, because it's not something we look at a lot, right, in stroke, despite the fact that it may have an important role. One thing we do look at a lot in stroke is perfusion imaging. So when we do these when we do perfusion imaging, we use something called dynamic susceptibility contrast imaging, DSC. That's the technical term for it. It's a T2 star weighted image. And it's collected while we're injecting gadolinium. It's kind of a video of the brain. It takes a couple minutes to acquire. And it turns out you can actually process these images not only to get blood flow, but also to look at the blood-brain barrier. So I'll just show you how this looks. So here's the source images of a perfusion scan. So this is one slice in a person's brain and going sort of across the top and then across the bottom. That sort of time. Each picture is about 1 second apart. And this is while you're injecting the gadolinium. This is a T2 star weighted image. So gadolinium creates this susceptibility artifact, or that darkening of the signal. So you can see the gadolinium washing in and washing out. It's a little late to come in the right radiologic right hemisphere, and it's delayed in leaving the right hemisphere. So this person's having a right MCA stroke. So that's all pretty standard. Now, if you took any one of those voxels and you plotted it, the signal change over time, this is what that would look like after you put it through a logarithmic function to turn it into a concentration. So you get this sort of spike in gadolinium concentration, which then kind of goes back down again. You can have the second pass effect. So this is as the blood is recirculated and come around again. And then the signal should kind of go to zero over the next several hours as the kidneys excrete the gadolinium. So we have some standard metrics we pull off of these. So this time to peak, that's how long it takes to get to that peak concentration. It's very similar to the Tmax. The Tmax is just more of an absolute number, whereas time to peak is more of a relative number. But that's an important metric that we use a lot. You can also look at the mean transit time. That's the width of this, the amount of time it takes for the bolus to go through the tissue. And then the area under the curve is the cerebral blood volume, another metric that we look at a lot. And this is actually used a lot in brain tumors because it's been shown that you can estimate tumor grade by the cerebral blood volume of the tumor. And that actually was where I first stumbled on this in the brain tumor literature, where you had these what they were demonstrating is obviously, brain tumors have a lot of blood-brain barrier disruption in some cases. And so they found that when the gadolinium leaked, it altered the signal and made it so that in their mind, you were underestimating the cerebral blood volume because of how the signal was behaving. It was getting pulled down like this. And so this was a paper where they proposed a way to correct for that. But what we were interested in more was the blood-brain barrier disruption itself. And so we focused on isolating that component. And so that's what the imaging that I'm going to show you is based upon. So this is an example of a stroke patient who came in, had sort of a complete right MCA syndrome, and we were just about to put the patient into the MRI scanner, and they normalized. So essentially recanalized clinically, they went back to normal. And so this MRI was acquired within minutes of recanalization of the tissue. You can see on the diffusion scan that there is an area of injury that occurred. And there is also a perfusion abnormality more distally, which is probably the clot has sort of traveled further along the vessel. So there is some hypoperfusion there, but we're going to focus in on this area that's been reperfused. And actually you can see here, because it's a little bit dark, that means it's hyperemic. So that's increased blood flow to this recently reperfused ischemic injury. So this is the perfusion source images for this patient. So you can see as we go along that the signal sort of brightens up in the area of the injury. And this is just a video of that. So as the gadolinium washes in, you can see that brightening signal. So this is sort of a very dramatic example of blood-brain barrier disruption and how it's visualized on the source images of a perfusion scan. Now, if you put a region of interest in that area and compared it with the contralateral hemisphere, you'd see that same thing that was described in the brain tumor literature, where the signal is being pulled down, the blue signal here, and red would be what it would look like in the absence of blood-brain barrier disruption, where the signal is purely due to the intravascular blood flow and the gadolinium related to that. So it's really this, you can sort of separate these two out, take the perfusion signal and separate it from the blood-brain barrier signal. And then when you isolate the blood-brain barrier signal, you get something called K2. And so you can make these images. You see this blue image here is the sort of the K2 values that we extract. And then we threshold that, overlay it on the source images so you can see the anatomy behind it and give it a sort of quantification. And in this case, there is actually T1 post enhancement that we can see. Of course, the T1 post enhancement is binary and also not very quantitative, and to a certain extent, in some cases, can be subjective. So this other method kind of gives us a way to quantify and really study the blood-brain barrier in a lot more detail. Now, a lot has been published about the blood-brain barrier in stroke, and this comes from the animal literature. It's one of my favorite little cartoons. But if you look at the time of occlusion, there's this, and so the blue is sort of blood flow. You start to have this opening of the blood-brain barriers, and that's sort of more of a mechanical failure of the BBB. And then with reperfusion, you get this hyperemia and this sort of acute opening of the blood-brain barrier. And that's the example I just showed you. So we caught somebody right at this peak, and that's why the BBB was so wide open. But typically that is transient. And then there's this biphasic opening of the blood-brain barrier that happens. Usually this is sort of in the hours after the stroke, and the second phase is in the days after stroke. And so we can see this in humans now, because we have this method that we can sort of, every time we do a perfusion scan, we can look at their BBB as well. And so here's that patient from earlier where we had a very early MRI scan, perfusion abnormality, diffusion abnormality. And then, so this is the blood-brain barrier image. So you can see that the BBB was starting to open in this patient as well. This patient was treated with TPA, as we showed earlier, and had complete reperfusion, and also had a reversal of the blood-brain barrier disruption, which is consistent with the animal literature. And to be clear, if the blood-brain barrier is very severely disrupted and you revascularize it, you can have blood-brain barrier rupture, and it can lead to hemorrhagic complications of treatments. So, the BBB is small amounts of change usually can be reversed, but when it's very severely injured, that is a risk factor for hemorrhage, and an important thing to keep in mind. Now, this patient, as they've scanned at multiple time points, you can see how they sort of fit onto the different time points of the BBB, and we think really this was 7 days after onset, and you see this sort of appearance of subacute, basically enhancement of the lesion, and we think that's in the second window here. So it gets the question of why we've all had this, right? We get a subacute MRI scan on somebody who has a stroke, and the radiologist says, looks like a subacute stroke, can't rule out tumor, right? Because it's enhancing, but not all strokes enhance. So what is that when we see a subacute stroke enhancing? Well, when you look at sort of the role of the BBB in this stage, it's thought to be affected by inflammation. So this is another way to look at the phases, showing that you have this reversible phase, which is not thought to be necessarily deleterious, but maybe MMP2 mediated, whereas then in the later stage, in sort of 5 days or so after stroke, you start to get an irreversible opening of the blood-brain barrier that's reflecting sort of inflammation and possibly continued injury. So what are the relevance of blood-brain barrier disruption in a subacute stroke? So we looked at this, obviously, because we had the data at the NIH. It was a pretty straightforward thing to look at. So we looked at post-stroke blood-brain barrier disruption and how that played into functional outcome. So how well did people recover after their stroke? So we had 2 time points initially from the NIH data that we could look at. The first one was 24 hours. And this actually right off the bat shows that, so if you look over here in the patients who have a modified Rankin score greater than 1, so these are people who did not avoid disability, their blood-brain barrier disruption was significantly higher, even 24 hours after the stroke, than those who were able to get back to essentially normal function. And then it was even more pronounced when we look at the 5-day time point, where we have again this 5 days after stroke, the amount of blood-brain barrier disruption is telling us about how a patient will do in several months later. So basically, from this odds ratio, it indicates that every 1% increase in the blood-brain barrier permeability measured 5 days after the stroke, the chance of having a good functional outcome 1 to 3 months later is decreased by 75%. So that leads to the question of, is this a target for treatment, and is this playing a role in people's recovery? If we could potentially alleviate this, could we not aid in recovery? This one of the first studies that I'm aware of to look at this was the ACTION study. They tested natalizumab, more commonly known for its application in MS, in stroke patients. It's a bit of a complicated study. The first round of it looked promising. The second round didn't, and then they shelved the whole thing. So we never got a full answer to this question. But I was able to work with the people who did the studies at Biogen and able to perform a perfusion analysis of the patients in the trial. And basically, we were able to replicate what I just showed you from the NIH data, but in a clinical trial, and found essentially the same thing, where there was this worse blood-brain barrier disruption was associated with worse functional outcome. We only could do it at the 24-hour time point, but the odds ratio and the p-value were almost identical. So sort of independent validation of this phenomenon, and this is the publication of that data. So I guess that leads me to the question of could we promote recovery by suppressing inflammation? I think, that's still an open question. I think you're going to see it's a space that a lot of people are focused on. And I think that I've kind of flipped it a little bit and said, rather than, are we promoting recovery? Are we trying to alleviate the things that are suppressing recovery, which I think is an important way to think about it as well. So just to summarize a bit and talk about some future directions. I mentioned that early changes in water diffusion correlate with clinical recovery in the hours after stroke. It's still kind of unclear what this means at the cellular level. And it's still unclear if this is truly recovery. Is this something else? Is this some sort of partial infarction, some sort of stunned tissue or something like that? But it's the only thing I've seen that appears to be predictive of recovery after stroke. And then disruption of the blood-brain barrier in the days after stroke, certainly we've shown in multiple studies now that it associates with functional outcome. Whether or not, if we alleviated this, we would be able to get more recovery. I think that's also an open question, but certainly with the BBB imaging, we can track, the risk. We can assess the risk, and then we can track the response to therapy if we were going to test a drug to do that. And then, what else could we be thinking about to try to look for recovery after stroke? There's a lot of other types of sequences that we're looking at. So CEST imaging or APT imaging. This is, looking at some of the other hydrogens, not the ones on water, but the ones on amides and so forth, and using that to try to estimate things like pH or proton density, that kind of thing. And so, that's an area that's sort of ongoing that we're looking at in the acute setting, but it also may have a very interesting role in more chronically. Other, interesting methodologies are emerging as well about measuring oxygen extraction fraction and that kind of thing. And that's been able, a lot of advances in doing that with MRI also could play a role. And then I think we have to think about what other factors might be influencing recovery that we could target. And a big one that I focus on a lot, just because of my research, is post-stroke cognitive decline. It's tough to imagine that somebody's going to have a good recovery after stroke if they start to have some sort of what I think of as a secondary injury, which is making it difficult for them to be part of the recovery process. And so I'll end with this example, which I think is an interesting one. It's definitely been very informative to me. So this was an 84-year-old woman who presented with sudden onset of right-sided hemiparesis, aphasia upon awakening. NIH stroke scale was 13. She had an MRI scan, because this was at the NIH. Everyone gets an MRI. Everyone gets a million MRIs. And the MRI showed restricted diffusion in the left frontal lobe. So this is the imaging for that patient. You can see the diffusion restriction on the DWI, the correlating perfusion abnormality. The flare is negative, so this person's actually in a pretty early window. There are chronic flare changes, which are important to point out as well, but acutely we don't see any significant changes. So this was a while ago, so it was when we were still using flare negative MRI to treat wake-up stroke as part of a trial. So she was enrolled in something called the MR Witness study, and she was treated with TBA. And 2 hours after treatment, her NIH stroke scale was down to 11, and then at 24 hours it was down to 5, and then at discharge it was a 3. 30 days later it was a 2, and then at 3, 6, and 12 months her NIH stroke scale was 0. And her modified Rankin scale, which was performed at 3 months, and again at 6 months, was a 1, but at 1 year it increased to a 2. And we weren't doing cognitive assessments on the patient, so I don't know why it increased to a 2. But when you look at her, what happened to the brain during this time period, you might get a feel for what's going on. So this was the blood-brain barrier image for the patient 24 hours after the stroke. So you can see at this time point, the stroke itself is not leaking gadolinium, although there is gadolinium that has leaked into the CSF from previous imaging. So there was blood-brain barrier disruption earlier, but right now the BBB is closed. But when you look throughout the brain, all this red and yellow and green is blood-brain barrier disruption. You see it often around these areas of flare change that we saw, even initially, that are likely chronic. And so when she had another scan done at 1 month, we see that actually most of this is persisting. So this is sort of this persistent diffuse disruption of the blood-brain barrier. You see now the stroke itself is leaking GAD. But even in this area that's contralateral, there's persistent blood-brain barrier disruption. And then even at 3 months, we still have pretty significant disruption of the blood-brain barrier. And so if you follow this area here over time, this is very remote from the lesion, but it experienced a lot of blood-brain barrier disruption for months. And when you look at the flare, how that changed over time, so this is at the first one's at 3 months, and then at 6 months, and then 12 months. And if you just look at this area here, it's almost as if the white matter disease has sort of consumed the stroke and become this this whole lesion we see over here. And actually, if you quantify all the changes over this time period in all of the white matter hyperintensities, you see in green here all of the new white matter hyperintensities that appeared over a 9-month period. And so, one of the questions is this, is this the secondary injury? Is this the disruption of the blood-brain barrier, the hallmark of what's to come, where you have this rapid progression of the white matter disease, which we know in many patients is associated with cognitive decline. So we wrote this up just as a case report, although I don't think it's that unique. I think this is actually probably a common finding and possibly one of the reasons that we see cognitive decline after stroke. So that's all I had. Happy to take some questions.